So certainly this was an interesting case. Um, it's not common for a uterine rupture at this gestational age, and we didn't know until we were in the surgery that there had been a uterine rupture. The patient presented in a lot of pain, and she had hemoperitoneum. And so the decision was made when her pain was worsening to go for surgery. The decision was made pretty quickly. She came in overnight, and immediately when the day team came in and we were able to do an ultrasound and confirm the large hemoperitoneum, we were able to get her to OR very quickly that morning. Um, and when we did the surgery, we discovered the uterine rupture, and had to make a game time decision. Do we repair it? Do we evacuate the uterus? Do we need to do a hysterectomy? Um, and given we were able to identify the source of bleeding, given this was a highly desired pregnancy for this patient, all of those decisions played into being able to repair the uterus and ultimately her being able to go on to successfully deliver at 32 weeks. One decision was it really was a shared decision making with the patient. Going to the surgery, we didn't know what we were going to find. We knew something was bleeding, but we weren't sure exactly what. Um, but we did know that this patient highly desired this pregnancy. So when we were in the operating room and we found this area of bleeding, um, it was a hard decision in the moment to decide what to do because it's not quite normal to repair a uterine rupture. What we did know is that it didn't occur in how it usually does. Usually, a patient comes in and preterm labor contractions that cause the uterine rupture. Here, the patient came in after basically a trauma that had caused it. So, given her high desire to continue the pregnancy, given we identified the source of bleeding and we had enough tissue to repair it, those factors all weighed into us being able to repair the uterine rupture. So, I think early steps are identifying what is going on, having a high suspicion, even in the right clinical scenario, that this can happen, that there can be a uterine rupture at 22 weeks, although it is uncommon. I think we were very early in getting diagnostic imaging, getting a CT and then another ultrasound to confirm this large hemoperitoneum. And then we were quick to get to the operating room to ultimately explore what the source of bleeding was. Um, I think an important decision um, that needs to be made in a similar scenario is what is the patient desire? And also, what was the clinical scenario that brought the uterine rupture about? I think that had she come in with contractions in preterm labor, we would not have made the same decision.